I'm an orthopedic surgeon that did specialty training in orthopedic oncology and revision total joints. My practice consists of primarily tumor patients, very complex revisions, hips, knees, shoulders, either for infection or other complex problems. I get referrals from about 7 states, primarily in the north region of Texas, including New Mexico, Arkansas, Oklahoma, Louisiana, occasionally Missouri, probably northern Texas as well.
Do you consider potential metal sensitization an important issue to discuss pre- or post-operatively with your patients?
Yes, we do. We are publishing a lot on metal ion sensitivities. It constitutes, with total knees, the second most common route for failure after a primary. If you look at infection, it's 1 to 3%, depending on whether it's a referral center versus rurals area. And it's also dependent on the skills of the surgeon. We've noticed that 1.5% of the people undergoing primary total knees will present with multi-directional instability and arthro-fibrosis. Statistically, it occurs at 1.5%. There's been publications of up to 14%. When we see the multi-directional instability, which is a clinical syndrome, these people present with restriction in terms of range of motion, or arthro-fibrosis, which is commonly associated with metal ion allergies, but they also present with pain getting up from a sitting position in the total knee, and also feelings of instability. They also have a propensity to form new bone, or what we call heterotopic ossification. Usually this is in the capsule. When you look at it on a CT scan, you're going to see a capsule that is thickened up to a couple of centimeters, and they all have effusion. The majority of the patients who were sent to us, we have a large peri-prosthetic joint infection practice. If you aspirate them, they're negative. The complaints from the patients are pretty severe.
How has Orthopedic Analysis metal-LTT testing helped patient outcomes in your practice?
Most of the orthopedic surgeons that make the referral do so because they think it is a recurrent infection that they just can't identify. In these patients, 85% will have a metal ion allergy or an allergy to submit on the basis of the LTT study. And it's at 1.5% of primaries, that's going to be a significant number. And we're publishing another paper not only on the mimicking infection, on the 85%, we probably have about 300 patients now that we've already revised. The patients are very unhappy because of the pain associated with the disease process. Usually their joints are warm, and that's the reason they think it's infected. If you look at the triphase bone scan, oftentimes you'll see evidence of loosening of either the primary or the revision, and they all have hypervascular flow to the capsule. The infection rate in this group of patients is 3 times normal, and we rely heavily on the LTT study because patch testing is very inaccurate for metal ion allergies associated with prosthetic device.
Which patients should consider metal sensitivity testing?
We published an abstract this year on people with multiple allergies. They should be tested before the surgery, in our opinion. The 1.5% that we see, we're seeing it after they've already had it done, and usually it's with the primary allergy that we see is to nickel. If they have a history of having jewelry problems, this is seen primarily in the female population. If you look at males to females, it's 2 to 1 female to male. Statistically, they're going to develop the allergies. And I think it's secondary to inoculation with things like pierced ear, etc. If they have a response to jewelry, they should be tested.